Evening to those of you who are just joining. We'll give it a couple minutes to let everyone get in and then we'll get started. I'll just get started with my preamble. So good evening, everyone. Welcome to our fourth Sunday supper session. So today's session is on the shoulder. We've got some excellent speakers lined up who are going to talk to you about some basic sciences and some elective and trauma issues regarding the shoulder. It looks to be an excellent evening. Before we get started, just some housekeeping for those of you that attended these before. If you've got questions, if you could please type them in the Q&A box, and we'll try and field as many as we can between each speaker. And our speakers will hopefully answer any unanswered questions by typing them out. And all of these sessions are recorded and will be up on YouTube once we get them uploaded. So if you do feel that we're running a bit fast and you can't make notes, just watch, and you can watch them back at your own pace at a later date. A couple of announcements to start with. First up is our virtual Congress this year. We've just launched our tickets. So for those of you who are interested, it's 6th and 7th of July. We've got 2 days of excellent talks from OTS, chamber debate. We've got our AGMs and paper sessions and some junior and student sessions. And there's a QR code for the registration link there. It is £54 to register, but the £50 gets refunded once you attend. Unfortunately, the £4 is a Eventbrite fee, but £4 for 2 days of excellent virtual teaching is an absolute bargain. And for those of you who are at ST3 or approaching the FRCS, we've got some pre-Congress courses which will be in person, COVID allowing, up here in Edinburgh. And those will be 1 day, and the links for those will be available soon, but they will be very reasonably priced and being run by experts in the fields. Our fellowship grants are still running, so if you're approaching your fellowship and you'd like to apply, follow the QR code there. We've got one £5,000 grant and a couple of smaller grants available to those of you who are BOTA BOA members and have a national training number and are about to go on fellowship. So follow that link and you can apply. And for those of you who are organising your fellowships, our Fellowship Finder website is up and running and filling up slowly with reviews. It's fellowshipfinder.org, so have a look on there and you can search for fellowships by specialty and region. And if you've just been, you can submit a review so that other people can see what your experience was. So without further ado, I'll hand over to Chris, who's going to introduce Rishi, our first speaker.
Hi there. So our first speaker is Mr. Rishi Dhir, and he's a consultant shoulder surgeon working in Harlow. He's also a FRCS teaching guru, and he has got a website and he runs lots of courses. And he's well known for anyone peri-FRCS, and he's come and he's done some teaching courses for us at BOTA, and he's hopefully going to sort of tell you about basic science of the shoulder. And on his courses, he'll show you how to organize your thoughts and dazzle the examiner, and hopefully give you something to fall back on should you go into meltdown at any point. And so on that note, I'll hand over to Rishi to tell us about the basic science of ligaments.
Thank you, Chris, for the very kind introduction, and to all the BOTA team for having me here tonight. It's a real honor to be here. So I'm going to talk to you about some of the basic science, and I've called it really the anatomy and biomechanics of the shoulder, because I think that's what the main basic sciences are about. As I do that, I'm just going to plug myself in because my battery is just showing low. Good. All right, so we'll talk about some of the osteology, the bones, stabilizers of the shoulder. We'll look at some of the movements of the shoulder. Very briefly, I'll touch on nerve and blood supply, and a brief touch on the prosthetic joint as well. So let's start with osteology. The shoulder joint should more correctly be referred to as the shoulder girdle or complex, because it consists of a series of joints working in concert together. And it can be thought of as three anatomical joints: the glenohumeral joint, sternoclavicular and acromioclavicular joint, and two physiological joints or spaces, the scapulothoracic and subacromial joint. Just to note, the subacromial space is about 9 to 10 millimeters in adults, and the space is significantly greater in men and slightly reduces in age. So in middle age, a subacromial space of less than 6 millimeters is considered to be pathological, and that may be because of a superior cuff tear or a subacromial spur. So let's move on to osteology. What are the bones which make up the shoulder joint? We'll start with the humeral head. Now, in terms of the anatomy of the humeral head, it's superiorly inclined, which means it faces upwards with a neck shaft angle of about 135 degrees. And that's important when you're looking at, for example, proximal humerus fractures and trying to restore normal anatomy. You really want to look at that neck shaft angle and get it right. There's also retroversion as well, compared to the transepicondylar axis of about 30 to 40 degrees of the humeral head. And it also sits slightly eccentric on the shaft. So it sits about 9 millimeters posterior to the neutral axis. So let's move on to the glenoid or socket. Now the glenoid is tilted superiorly at about 5 degrees. And that's important because when we look at patterns of wear over time, for example, with normal osteoarthritis or cuff arthropathy, we'll see different patterns of wear, and that 5 degrees of superior tilt may disappear. You'll also see retroversion of about 7 degrees in the to the scapular plane, but the scapular plane itself is antiverted, so sits slightly forward to the coronal plane, and that's important to prevent posterior instability. So just remember some of those figures, because that's the natural inclination of how the bones sit, which helps to provide some sort of stability, which I'll come on to shortly. So let's look at the glenohumeral joint. And although I've mentioned a number of different joints of the shoulder girdle or complex, I'm going to focus in a bit more on the glenohumeral joint because that's the one of main interest. So structurally, this is classified as a ball and socket joint, but functionally, it's a diarthrosis and multi-axial joint. Now, it's really important because it allows the greatest movement of any joint in the body, allowing you to effectively position your hand anywhere in space. But because of this movement, it's an inherently unstable joint because your priority is movement, whereas in the case of the hip joint, another ball and socket joint, your priority there is stability to support the lower limbs, essentially. So it can be thought of as analogous to a golf ball, the humeral head, sitting on a tee, the glenoid. As a result, because it's inherently unstable, it's the most commonly dislocated joint. So stabilizers of the shoulder are particularly important. And that's why it's such a common question that comes up in FRCS and a pathology that we see in our day-to-day practice as shoulder surgeons as well. So in terms of the stabilizers of the shoulder, I'm a simple man and I like to break things up very simply. So we'll break them up into static and dynamic stabilizers. So in terms of static stabilizers, firstly, the vacuum effect. The intracapsular negative pressure effectively sucks the head onto the socket. There's something called adhesion-cohesion effect. And what that is if you take two wet surfaces, such as the humeral head and the glenoid, when they come together, they effectively stick together, creating a bond known as adhesion-cohesion. There's the bony congruency of the different surfaces, which I've spoken about. So, for example, the humeral head is retroverted 30 degrees. The glenoid is retroverted 7 degrees to the scapular plane, which in turn is antiverted 30 degrees to the, it's retroverted 7 degrees to the coronal plane, which in turn is antiverted 30 degrees to prevent posterior instability. So the bony congruency is quite important. There's a concept known as the effective glenoid arc and the balance stability angle. So what do I mean by that? Well, the effective glenoid arc is the amount of glenoid surface which is available for articulation with the humeral head. So this part of the glenoid here is available for articulation with the humeral head. That's the effective glenoid arc. Whereas the balance stability angle is the angle between the center of the glenoid and the effective glenoid arc in all directions. And it's approximately 18 degrees anteriorly. There's the glenoid labrum, which is important because it effectively deepens this socket and contributes to this concept called concavity compression, which I'll discuss shortly. And there's also the capsule, which is a sort of loose fibrous tissue sitting around the joint, which has thickenings called glenohumeral ligaments. And I'll talk to you about some of the ligaments now. So let's start with the glenoid labrum. The labrum is a ring of fibrocartilage, which is attached to the circumference of the glenoid cavity. And this ring is continuous with the tendon of the long head of biceps, okay? So just remember, the long head of biceps is intracapsular. It's one of only two tendons in the body, the other being popliteus, which are intra-articular tendons. So the labrum, you can it can be torn at various different points. And I'm just going to briefly touch on this. So we normally think about the labrum as a clock face, okay? With 12 at the top, where the long head of biceps inserts, 6 at the bottom, 3 anteriorly, and 9 posteriorly. So you can have a tear from 10 o'clock to 2 o'clock, which is a superior labral or slap tear. You could have a tear from 3 to 6 o'clock, which is an anterior labral tear, or a tear from 6 to 9 o'clock, which is a posterior labral tear. You may have one which is of the entire labrum, which is a circumferential tear as well. So understanding these is important in working out patterns of instability and also subsequent treatments as well. So let's move on to some of the ligaments of the shoulder. And there's quite a few that you need to know about. There's the coracoacromial ligament, and this is a strong triangular band which extends from the coracoid process to the acromion. And together with the coracoid and the acromion, it forms a coracoacromial arch which overlies the shoulder joint, preventing superior displacement of the humeral head. There's the coracohumeral ligament, which passes from the base of the coracoid to the greater tuberosity of the humerus. And this blends with the supraspinatus and subscapularis tendons. And it's got two bands, an anterior band, which inserts into the lesser tuberosity, and a posterior band, which inserts into the greater tuberosity. There's the glenohumeral ligaments, which are thickenings of the capsule, which I'm going to talk about subsequently. There's the coricoclavicular ligament, and this is the one which we often see in ACJ dislocations. So it's a fan-shaped triangular ligament consisting of the conoid medially and the trapezoid slightly more laterally. And this is important for allowing alignment along with the acromioclavicular ligament of the clavicle and the acromion. So it prevents superior, I should say actually, rather than superior displacement of the clavicle, it stops the shoulder from dropping down. So that's important in ACJ dislocation. There's the transverse humeral ligament, and this spans the distance between the greater and lesser tuberosities, and essentially holds the long head of biceps within the intertubercular groove. So those are the ligaments that you need to know about. And the ones which most commonly are examined are these things called the glenohumeral ligaments. I'm going to go into these in a bit more detail. Now, the glenohumeral ligaments, as I mentioned, they're thickenings of the capsule, and you can often see them arthroscopically. And basically, these are important for stabilizing the humeral head in different positions of motion. So, for example, when your arm is by your side, the coracohumeral ligament and superior glenohumeral ligament is acting. In 45 degrees abduction, it's the middle glenohumeral ligament which is acting. And then in 90 degrees abduction, but external rotation, it's the anterior band of the inferior glenohumeral ligament which is acting, or internal rotation at 90 degrees abduction, it's the posterior band of the inferior glenohumeral ligament which is acting most strongly. So this is an important MCQ question which often comes up in the exam. So just remember that one for the exam. Which positions of abduction do the ligaments act most strongly in? So let's move on to the dynamic stabilizers. And I've taken this picture from Matson's book on shoulder surgery principles and procedures. And there's a number of different dynamic stabilizers. So I would say this is a mixture of muscular action and also proprioception. So the rotator cuff acts as a fixed fulcrum. So essentially it pushes the humeral head down into the glenoid, a concept known as concavity compression, and that's helped by the labrum, which deepens the glenoid, creating a concavity. There's the deltoid itself, which supplies a superior translational force, which you can see here. There's the scapular rotators, so the scapulothoracic muscles, and there's also the biceps, which prevents excessive translation and acts as a minor depressor of the humeral head as well. And I just mentioned about this concept of the fixed fulcrum. So I always think of it as akin to like a dartboard, which is fixed on a wall. You're trying to hit the dartboard with the darts, the deltoid. And if the cuff has gone and the fixed fulcrum has gone, it's going to constantly superiorly migrate, which is going to stop you from operating that shoulder properly, which gives rise to the concept of pseudoparalysis. So this concept of the fixed fulcrum, the cuff holding the shoulder in a fixed position, is quite important to get your heads around. Okay, and that's just showing you what I meant about concavity compression. So if you think about the glenoid, the concavity is not only from anteriorly to posteriorly, but also superiorly to inferiorly, and it's deepened by the labrum. And the cuff helps to fix the humeral head against the glenoid within that concavity. Force couples are also important, and this is coupling of forces by different groups of muscles. So it's important to understand about a transverse and a coronal force couple. So this is the coronal force couple between the deltoid and the superior cuff or supraspinatus. So when you have a massive cuff tear, you'll get unopposed action of the deltoid, causing superior migration of the humeral head. There is also a transverse force couple between the infraspinatus or posterior cuff and subscapularis or anterior cuff. So these are important force couples to think about in shoulder surgery as well. And that's important for your biomechanics. So going back to what I said about the force couples or fixed fulcrum, another analogy you can think of, and one of my former bosses at Wrightington, Puneet Monga, taught me this very well actually, was this concept of trying to keep a beach ball or a humeral head just underneath the water. The ball represents the humeral head, the waves represent the deltoid pushing the ball up and out, and your hand represents the cuff, just trying to keep it below the water. And these forces are all balanced. And so that's important when you have these massive cuff tears, you get loss of these force couples and you get superior migration and superior patterns of glenoid erosion. And this is commonly seen in things such as rotator cuff arthropathy subsequent to a massive cuff tear. So let's move on to movements of the shoulder, okay? And in terms of movements, you've got mainly glenohumeral and scapulothoracic motion in a ratio of 2:1. So majority is glenohumeral with a small amount of scapulothoracic. And these are just the different positions that the movements act in. So you start off with mainly glenohumeral, then scapulothoracic kicks in such that both are acting. And then at the final part of your motion, the extremes, it's mainly scapulothoracic. There is also a small amount of thoracoacromial movement as well. So movements of the shoulder joint are quite complex and are not just simplified to just the glenohumeral joints. So think about it in terms of those different joints acting in concert. It's important to have a quick appreciation of the nerve and blood supply. And in terms of the nerve supply, the suprascapular, axillary, and lateral pectoral nerves supply the shoulder joint. The blood supply is from branches of the anterior and posterior circumflex humeral arteries, and a smaller supply from the suprascapular and scapular circumflex artery as well. Now, in terms of the humeral head, a question you may be asked in the exam is, what's the more predominant supply? Is it the anterior or posterior circumflex humeral artery? Most commonly, it was believed to be the anterior circumflex humeral previously, but a recent study in 2010, well, I say recent, in the JBJS by Hetrick et al., which is a cadaveric study where they looked at patterns of dye injected and sequentially occluded the anterior or posterior circumflex humeral artery. And they found actually in about 64% of the blood supply comes from the posterior circumflex humeral artery. And this seems to fit with patterns of avascular necrosis seen after proximal humerus fractures. In about 80% of cases, it's the anterior circumflex humeral artery which is taken out, but often you don't see AVN in these patients, suggesting that the posterior may be the more dominant blood supply. I'm just going to finish off with a quick slide on the prosthetic joint. And that's because in the exam, they sometimes ask you about not only the biomechanics of the native joint, but also the prosthetic joint. So when you're thinking about biomechanics of the prosthetic joint, you will need to understand about the anatomical shoulder joint. And so with an anatomical, it's very important to get your glenoid positioned in exactly the correct position without excessive bone loss or retroversion and with a good functioning cuff. And that's because we want to concentrically load the glenoid component. If you've got a deficient cuff or you've got excessive retroversion and you've positioned the glenoid component incorrectly, you're going to get eccentric loading of the glenoid component, which is going to lead to what's called a rocking horse phenomenon, where you eccentrically load the component and it leads to early failure because the main mode of failure is on the glenoid side. The other thing you might be asked is an understanding about the biomechanics of the reverse, and you only need to know this in very, very simple terms. So typically, the center of rotation is at the center of the humeral head. Now, in a cuff-deficient shoulder, you're relying upon the deltoid to move that humeral head. And so what you want to do here is you want to medialize and inferiorize the center of rotation. And as a result, you're effectively increasing the lever arm on the deltoid. Now, we talk more recently about slightly lateralizing the component. And what we mean by that is not lateralizing in relation to the native center of rotation, but in relation to the more medialized center of rotation, basically. So that's something you may need to know very, very briefly for the exam, just understanding about medializing and inferiorizing the center of rotation in a prosthetic joint. So in terms of further references, I use some pictures and also passages from Matson, Shoulder Surgery Principles and Procedures. It's a very good book, and there's certain chapters which are very useful on anatomy. They explain the rocking horse phenomenon very nicely as well. The paper from Williams, Rockwood and Bigliani from 2004 about rotator cuffs and looking at the anatomy of that is also very useful. Professor Funk's fantastic website, Shoulder Doc, is always a boon for us on all kinds of shoulder surgery as well. So I'd really recommend that to you guys as well. I'm sorry I've taken up some time there. Any other questions? If there's anything I've not mentioned or you've sent to the chat, please feel free to email me. That's my email, letstalkdrrishi@gmail.com. Please check out my website, letstalkdoctor.com, or check us out on Twitter @talkdoctor or on Facebook, and please smash me a like. We have got some courses as well, covering all different parts of the FRCS and all different parts of training. And I've got a discount code for you guys called BOTA10, which you can use at checkout as well. So please feel free to check that out as well. Thank you.
Great, thanks, Rishi. I don't think we've got any questions at the moment, so we'll just move on. And if anyone does have any questions for Rishi, if you could just type them in the Q&A, we can always come back to him if time allows. Thanks.
Thanks very much, George. So it's an absolute pleasure to introduce our next speaker this evening. Professor Funk works as part of the prestigious Upper Limb Unit in Wrightington Hospital, as well as in his private practice at the Arm Clinic in Manchester. His specialist practice focuses on sports and soft tissue injuries of the shoulder, and a large volume of his work involves providing second opinions, treating complex cases, and performing revision surgery. Professor Funk is passionate about education of both patients and medical professionals, and he established and runs the shoulder education website shoulderdoc.co.uk. His extensive academic portfolio includes authoring numerous books, and he's incredibly active in his research with over 100 research publications, and he regularly presents at both the national and international level. He teaches both undergraduates and postgraduates, and as a medical student at Manchester University, I experienced firsthand what an enthusiastic and outstanding mentor Professor Funk is as a role model to those wishing to pursue a career in shoulder surgery. It's a great pleasure to introduce Professor Funk's talk this evening on shoulder instability.
Thank you, Tom, and thank you very much to BOTA. I really appreciate this. And, you know, the best part of my job after, you know, more than 20 years has been to see people like Tom when he was a young medical student and watch them go through their careers. Tom contributed to a few of the research papers when he was a medical student, both during his training bits, but also on holidays. And I learned a lot from him, and I still learn a lot from the students and the fellows. So thank you very much, guys. You know, you guys have all got a very exciting career ahead of you. You know, I wish you all the very best. I'll share with you some words on shoulder instability. First, I'll share with you my screen. So, you know, it's Sunday evening. I'm not going to rack your brain with an hour-long lecture, unless you want me to. But just give you a guide to thinking about shoulder instability. And what was brilliant is Rishi, an ex-fellow of ours who's done fantastically, presented a lot of things that I've been able to take out of my talk. So it's great. I can do a little more on some other things. So, you know, shoulder instability, it can be a little bit confusing because there's so many different types of instability, and when you go to different conferences around the world, there's a lot of regional variation. So I'm going to give you the British regional variation. Rishi covered very well the static stabilizers of the shoulder, and the dynamic stabilizers are part of this as well, which I'll highlight. I like to think of you know, the shoulder complex, because it's not a joint, it's a complex, as a dog, which is the scapula, standing on an unstable structure, which is the muscle supporting the scapula, standing on the floor, which is the spine and kinetic chain, and then the glenoid nose trying to balance this humerus on the end of it, which is, as Rishi pointed out, bigger than the cup. And the shoulder really has only one role in life, and my hand surgery colleagues love that. Its only role in life is to position the hand in space. It has no other role. So we as shoulder surgeons are there to serve our hand surgical colleagues. I want to just highlight the dynamic stabilizers because they're very important. You've got the movers and the shakers. The movers are your big scapular muscles that transfer the energy from the trunk to the arm. These are things like your deltoid, lat dorsi, pec majors. And then you have the fine tuners, the shakers, and that's your rotator cuff. And your rotator cuff, there's a centralizer and stabilizer. So 2/3 of the stability of your shoulder comes from these dynamic stabilizers. So obviously we as surgeons spend a huge amount of time focusing on the little labrum, but the labrum contributes a very small amount to the overall stability. So these muscles are very key. In addition to that, you know, within the ligament folds of the capsule, there are key mechanoreceptors, and these mechanoreceptors provide proprioception. So when you dislocate your shoulder, stretch out your shoulder and tear your labrum, these mechanoreceptors are damaged. So that's an important part, not just fixing the labrum, but also dealing with restoring proprioception to the joint. And with recurrent dislocations, you will lose more proprioception. The kinetic chain I mentioned earlier is key. So just focusing on fixing the shoulder is not enough. We need to start from the ground up and make sure that they have good stability. So if you are listing a patient for surgery, a thing called prehab is essential, where they can work on all these components before you go and put an anchor in the labrum. In terms of classifying instability, the basic classification is the Tubbs and the Ambry. So the traumatic, unidirectional, usually a Bankart tear, usually treated with surgery. On the other extreme is your atraumatic, multidirectional. They tend to be bilateral and treated with rehabilitation. And there's a range in between of these. So that's what we'll deal with, is trying to understand and pick apart the range. And this really made it more understandable for me, and this is what I follow, and I think in the UK, but not well recognized overseas. So you guys need to go and spread the word. This is from Ian Bailey, and we call it the Stanmore classification. There's just the one publication there, and it's a brilliant read. But even better than that, he kindly let me put on YouTube one of his lectures that he gave in 2014 after he'd retired. And you know, if you've got half an hour to spare with a real interest in the history of instability and trying to understand it, that's a good watch and read. But I'll give you a potted version now. So instead, in the way we think about instability, we have a triangle. So the polar one is your typical rugby player, and they will have an injury, dislocate, and have large structural lesions, so traumatic lesions. Then you have your polar two. So if you think about your gymnast who's hypermobile, got stretchy joints, and lives on the edge of instability with their stretchy joints, they have a minor injury, so slight overstretch on the rings, and then they start to become unstable. So that is a minor traumatic, but still a structural injury. So they go from a compensated laxity or instability to an uncompensated instability. And then you have your polar three, and this is quite a rare group, and that is no history of any trauma at all. The type of guys who did a party trick, which then becomes an uncontrolled party trick. And that's a motor control instability. So they can either voluntarily sublux or dislocate, but also can involuntarily muscularly sublux or dislocate. And what's key is to remember that there's a range. So you get patients that are polar 1, stroke 2, and that would be, say, a rugby player who's hypermobile as well, and they do exist, and they have an injury and laxity, but they have large structural injuries as well as proprioceptive issues, as we said. Then you get the range of polar 2 stroke 3s, and this would be your gymnast who dislocates and then develops motor control issues. And that's a very common one that we see in our specialist shoulder clinics. And patients will change over time. And that's what this classification allows us to understand. So recognizing that patients change over time. And the beauty of the classification is it really helps to guide my treatment for me. So polar 1 will have large structural lesions, and they usually need big reconstructions. Polar 3 has no structural issue and no structural pathology, and therefore is purely a rehab issue, focusing on those things which are highlighted around muscle control, kinetic chain, proprioception. And then your polar 3 is somewhere in between. Now your polar 3, they have both big muscular issues, they have minor structural lesions, and they have the laxity issues. So for them, it's a fine combination of rehab and surgery and different types of surgery in the forms of plications and resetting the proprioceptors. So for those sort of patients, it helps, you know, you have a 2/3, and we want to shift that patient from a 2/3 to a 2. And then if they still have issues, consider possible surgery, but many will do well just with rehab. So that's thinking about instability as a whole and putting it into broad categories. But when you actually see a patient with instability, this is my way of thinking about the patient. So are they involuntary or are they voluntary to start with? So voluntary, they're doing party tricks. They don't need treatment. Just stop doing party tricks. Involuntary, they are either traumatic, had a history of injury, or atraumatic. Of the atraumatic, we want to look for, is there hyperlaxity? Is there repetitive overuse, such as a throwing shoulder? So a minor traumatic, repetitive overuse issue. And then the direction, which direction are they coming out? Is it anterior? Is it posterior? Is it multi-directional? And is it an acute dislocation? Is it chronic, or is it a recurrent dislocator? And then is it a subluxation or a dislocation? So which is it? And these all tell you a lot. Now, you get this from your history and examination. So the vast majority you'll get from your history. So is it traumatic, atraumatic? That's your history. Your direction, you'll get an idea from the history, but also from the examination in terms of true instability. Whether it's acute, chronic, or recurrent from your history, and is it subluxations or dislocations, again from your history. So your history will give you a lot of information. So let's look at, I'll skip that, some case examples. So the difficulty here is I can't get you to yell out the answers, but you can put your hands up, because that little spot in the ceiling there is me watching you, and hopefully there is some yous out there. So case one, a 22-year-old male, semi-pro rugby player, first dislocation was 6 months ago, relocated in A&E, 3 recurrences with rugby in abduction, external rotation positions, always requiring a relocation, wants to get back to rugby. MR arthrogram showed a bony Bankart lesion and a haggle. So we can tell he's traumatic. We can tell it's a dislocation, so it's a true dislocation. It's more than one, it's recurrent, and it's anterior. So this is clearly a very polar type, polar 1, with a large traumatic anterior structural lesion. So for him, it's going to be surgical reconstruction. So that's one extreme. Next one's a 17-year-old female drama student, can't remember any specific episode of her first dislocation, has lots of recurrences, just simply dressing and simple daily activities, it comes out, and she's afraid to perform any frontal activities. So that's where she's apprehensive, in that position. And she's struggling with daily activities. Her MR arthrogram is normal. So let's see, she's atraumatic. She doesn't recall a specific episode. She's recurrent because it happens all the time. There's subluxations. She's not had any true dislocations requiring relocation. And she's posterior because it's frontal plane that she's struggling, not in the ABA position. So she's a polar 3, and for her, you don't need to operate. You send her for specialist shoulder rehab. Now, here's our girl we're talking about already. You know, she's same age, gymnast, painful for 2 years. and she was training a year ago and it slipped out. So she recalls a specific episode. It's not a major episode, but she recalls an episode, and it continues to be slipping when she's training, not daily activities and not atraumatic. She's struggling. She obviously has hyperlaxity. She's a gymnast. And MRI shows a small rounded labrum and a capacious capsule, no obvious big tear. So she's a minor traumatic. It's recurrent. She's subluxing. She might be multidirectional. We're not too sure. And she's a polar 2. She's atraumatic structural, and she'll be one of these where we discuss the roles of relative rehab and or surgery, and we have determinants in our examination, which you don't need to know for your exam, to assist us knowing whether we go the rehab route or the surgical route initially. So next one's a 90-year-old male, footballer, goalkeeper, 1 year ago, dislocated, so clearly traumatic, 15 recurrences, now relocated himself, can't get back to sports, he's apprehensive in ABA, so he's anterior, it's recurrent, he's got a Bankart tear and a slap, and he's going to be a type 1 traumatic, but a little different to that rugby player. Here's another one, 58-year-old male, fell down the stairs, dislocated, so twice relocated, very weak, 58, rotator cuff tear. I have my warnings, and he's for a rotator cuff repair. So final summary, so polar ones, structurals, they often traumatic, dislocate, anterior, posterior, and they're usually surgery. The polar 2s, they're atraumatic, structural, they could be either anterior, posterior, often recurrent, subluxing, as we said, a little bit of both. And the polar 3s, no trauma, recurrent, usually posterior, but not always, and they're not for surgery, they're specialist shoulder rehab. So this talk is available on SlideShare, but my email's there if anyone wants to get in touch. Thank you very much. Over and out. Back to you, Tom and George.
Thank you very much for a fantastic talk, as always, Professor Funk. I just had one question from one of my colleagues, actually, in the Welsh rotation, who's asked, in polar 3, who are still symptomatic after rehabilitation, would you consider surgery? And how long would you give rehab before considering as a non-responder?
So rehab has to be with a specialist shoulder therapist, not with any physiotherapist, and absolutely no surgery. Surgery is not there for failed physiotherapy. Surgery is there for the correct indications. In terms of rehab, if they have the right rehab, you will know by what we call modification tests when you do the examination. So I've learned the modification test from our therapists. We do modification tests, we know, and then the patient knows they'll respond to rehab, and the type of rehab they'll have will definitely not be the same as they'll have had before. So in answer to your question, no to surgery for failed rehab, and to get them to see specialist shoulder rehab, and they will improve.
Thank you. We've got another question from Sanjay Shetty. He's asked, does the Stanmore classification cover first-time dislocators? Otherwise, what's your suggestion for management of first-time dislocation in various age groups, please?
Well, it does cover it. Absolutely. Stanmore is not about the frequency of dislocations, as you saw. different age groups? Yeah, well, if we're talking traumatic, okay, to keep it simple. So number one to realize, sorry, it's a big question. Number one to realize is that shoulder instability is a self-limiting condition. So it will, with age and time, your shoulder will stabilize, it gets stiffer, okay? Secondly, recurrence rate in traumatic dislocations is higher the younger you are. So under 20 is higher, under 16 is higher than under 20, 20 to 30 is higher than over 30. So, and thirdly, as we saw, over 40, for example, it's normally rotator cuff tears rather than capsulabral pathology. So in terms of treatment, you need to take into account those patient factors, age being only one of them, the environment, so the performance factors, that needs to be decided on, and then also your ability factors and facility factors. So those all need to be decided in terms of your management. So it's impossible to answer. You don't treat according to one factor. Get a book called Diagnostic Clusters of the Shoulder. Munger and Funk.
Thank you. If anybody else has got any questions, Professor Funk, to answer, please put them in the chat and we can answer them during the next presentation.
Okay, in that case, if that part of the talk is over, if I could please introduce Mr. Nick Aresti. So Nick is a consultant orthopaedic surgeon at Barts Health, where he obviously specialises in upper limb surgery. Trained in London, fellowships at Addenbrooke's and the BOA, travelling fellowship to the USA, and then also took time out to do an FMLM National Medical Directors Fellowship at the CQC. He's an honorary senior clinical lecturer at humeral, where he teaches on the TNO Masters, and he was born and raised in North London, where he still lives with his family, and as I know, is an avid cyclist. So thank you very much for joining us, Nick.
Hi guys, let me just share my screen. Can you see the slides there?
We can.
Great, okay, thanks very much for having me, everybody. So I've been given the task of talking about proximal humeral fractures. When I was on fellowship, one of my fellowship bosses said to me that any bright or clever shoulder surgeon will avoid proximal humeral fractures as much as they can, because you're damned if you do, you're damned if you don't, and we don't really know what the right answer is. And the more I practice, the more I realize he was completely right. So it's a massive topic, and there's loads you can read online. So I'm just going to try and focus in on some of the more contentious points and the things that I think are relevant. So just to start with, there's a huge spectrum of fractures, and we've traditionally been taught to think about them in terms of parts, so 1, 2, 3, 4 parts. And that all came out of Nir's original work, which was published between the 50s and 70s. Interestingly, I think the reason why we have those predictable 4 parts of shoulder fractures, the greater tuberosity, lesser surgical and anatomical neck fractures, is because the shoulder will fracture along weak lines, which are there because of ossification centers and physes. So that's why you get kind of those predictable patterns. So what Nir did and his colleagues is come up with a classification system, whereas there was 1 to 4 parts, and then also they thought about whether it was because of a dislocation and which side the dislocation came from. And as I said, we have been taught to think about a part as having displaced either a centimeter or 45 degrees. Later on, so one of the original papers that Nir wrote was co-authored by this guy, Thomas Brown, and he kind of confirmed that those figures of a centimeter or 45 degrees were basically arbitrarily set. So don't fall down the trap of, oh, it's not a centimeter or it's not 45 degrees, therefore it doesn't count as a part. Because sometimes it does, particularly in the context of how that fragment sits with the rest of the shoulder. So once those parts break, it's important to recognize what pulls those parts aside. So as you can see from this diagram, the greater tuberosity is pulled by the superior and posterior superior cuff, the lesser tuberosity by the subscap, the shaft of the humerus by the pec mainly, and the head kind of sits where it fractured out. despite us being orthopods and thinking we like fixing fractures and fixing bones, proximal humeral fractures are really soft tissue injuries. So as you're fixing them, you realize that getting those cuff tendons really caught in some good suture and wrapped around a plate will allow you to fix the fracture. It's not a bony problem, it's a soft tissue problem. And that's why the pull of these muscles is really important to appreciate. I won't go on about this because we've already touched it. We know that the vascularity comes from both the anterior, posterior, circumflex vessels, and you have this arcuate artery coming up the bicipital groove, which is also important in vascularizing the head. Fortunately, vascular injuries to the proximal humerus aren't common. When they do happen, they're generally because of an injury to the axillary artery, particularly in atherosclerotic people, not necessarily because of the anterior and posterior circumflex arteries. I think one of the problems with orthopedics, particularly in the UK, is we're hung up on the hip, and the majority of our surgeons are hip surgeons. The vascularity of the humeral head doesn't really matter, and I'll explain why in a bit. The other thing that's important to remember is what nerves get injured. So this is a good study to remember. Visser in 2001, this group basically did EMG studies of people who came in with proximal humeral fractures, and they looked at near one eye undisplaced and displaced fractures. And as you probably already knew, the most common injury was to the axillary nerve and secondly the suprascapular nerve. I'm pretty sure in my Part A exam, there was a really weird question. I can't remember whether it was about fractures or about dislocations, but it asked what the third most common injured nerve was. So it's probably worth trying to remember this. So the concept of predicting vascularity is actually easier than you probably would think. Hertel, who's a Swiss surgeon who visited us a few years ago actually at Barts, didn't come up with the constants, but he elaborated on the concepts of vascularity by using his Lego bit concept. So red meaning the head, the green is the shaft, and the blue is the greater and yellow lesser tuberosities. And based on the fact that there are those 4 parts, there are 12 predictable patterns of fracture. And he looked at each one of these patterns and came up with the risk of avascularity, i.e. the risk of losing a blood supply to the humeral head. Now, bearing in mind these studies are fairly old now, so they're not particularly sophisticated. It was done with Dopplers, or sometimes even more rudimentarily by drilling a hole in the humeral head and watching to see whether it bled or not. And so he basically realized that it was these fractures which led to the biggest compromise in the vascularity. And what you can note from all of these, it's pretty simple. It's when the head is severed from the rest. The other one, the other fracture pattern which had quite commonly lost its blood supply was number 7. I think they concluded that sometimes what happens, you have an anatomical neck fracture, but then it kind of compresses down into the lesser tuberosity. And in a plain film particularly, you can't recognize. So try not to get caught out by these ones. The other thing that Hertel and the group described was these accessory criteria. And what these basically kind of mean, so the first few, is whether or not the vascularity is injured at the metaphysis, where those vessels are coming off the axillary artery, and also whether the head split and or the shoulders dislocated. So looking at these diagrams, this is the kind of calcar, the metaphyseal hinge. So if there's a long hinge and the blood vessels are coming up quite close to the head, the argument would be that they're maintained, and so the vascularity is therefore maintained. But if a fracture is much closer to the anatomical head, then you're in more trouble. And quite simply, if you've got loads of comminution in this calcar region, if the head tips into varus, you don't need Hertel to tell you that the vascularity is more likely to be affected. So just keep an eye out for those when you're looking at x-rays in the trauma meetings. The other thing, of course, is if the head split, bad news. Now, what I was saying earlier, does it matter, right? So we know that there are certain fracture patterns where the head becomes ischemic, but what effect does that have? And I like Professor Funk's analogy that the shoulder is there just to serve the hand. So what does it matter if the shoulder doesn't work properly? So Hertel looked into this in more detail, and I'm sticking to Hertel because is Lego brick, but this has been done numerous times. Gerber's the other big notable surgeon who did some of the studies, and forgive the wordy slides, but what I'm just showing you here is they looked at two groups intraoperatively. So one group where the humeral head was perfused, and group B where it wasn't perfused. And within those, they looked a little bit more about the structural altercation. But what I want to show you from this is that the probability of the head collapsing, i.e. because of AVN, in the first group, i.e. the vascularized group, was 13%, and in the ischemic group was only 20%, so i.e. 7% more. So these aren't huge figures. In the hip, we're talking about 25 to 30% risk of AVN, and that will mean that people can't walk, they're in bed, cardiovascular compromise, frailty, etc., and it's life-threatening. But it's not so much the case with the shoulder. And then also looked at structural altercations, and again, the difference between the constant scores between the structurally altered and the non-structurally altered humeral heads weren't that dissimilar. So it goes, begs the question: so what if the humeral head becomes ischemic? Is that going to change the outcome for the patient? Now, you can't talk about shoulder fractures without talking about the Prof study, and I know you've all probably seen this and you've got to know it for the exam, but essentially over the course of 2 years, whether or not you have shoulder surgery, according to Prof, won't affect your outcome. And I know there are lots of kind of, in inverted commas, problems with this study, but actually, bearing in mind that the majority of orthopedics is based on what my boss used to do and what he or she taught me, actually the Prof study is one of the best trauma studies we have out there. And yes, you could probably pick holes in it, but it does give us, tell us a lot of important things that we kind of probably knew, but we weren't willing to accept. And that is that for the average shoulder fracture, surgery doesn't really make a huge difference. And when they stratified for age, which is one of the criticisms, and for whether or not the tuberosities are involved, another criticism, again, doesn't really make much of a difference, whether you have an operation or not. Then other people turn around and say, well, that's only 2 years. What about later on? And so follow-up studies, exactly similar things. So over the course of 5 years, if you break your shoulder, the chances are whether you have an operation or not won't really matter. And the number of people who needed further operations in both groups didn't really change as well. So what Prof, in my mind, tells us, when you don't really know what to do with the shoulder, whether or not you need to fix it, you probably ought not to fix it. So that obviously confuses a lot of people. And I keep saying with things like proper seesaw studies, they're there to help guide our decision, to inform us. They shouldn't dictate what we do. So when you see a proximal humeral fracture, you shouldn't turn around as a knee-jerk and say, well, Prof told us we shouldn't really do anything. You should just help it make you decide what to do with these patients you're really not sure about. So in my mind, I think the majority of patients, I don't know what to do. The undisplayed simple fractures going on up, and the ones which are completely catastrophic, you might want to do something about. But for me, the vast majority, I'm not really sure whether an operation will help them. And that's when I use the likes of Prof. So I probably haven't really helped you. I probably confused you a lot about what all these studies show. So I just thought I'd kind of give some more facts that might help you in your day-to-day kind of trauma rounds. But when these are the kind of things that I look at for offering an operation. So if somebody's come with a proximal humeral fracture and a dislocated head, particularly obviously if it's still dislocated, they're getting an operation. If the head's not facing glenoid and that's either sunk down or facing posteriorly, they're going to get an operation. Same with the head split. The GT is a slightly harder thing to tackle for me, but I don't really think that you can use some of the rules which are in some of the books about 5 millimeters of displacement, because you don't know, firstly, the trajectory the X-ray has been taken in, and so much of it depends on the patient. But if you've got truly displaced GT, particularly if it was a fracture dislocation, I'd be thinking about surgery. Then the next one is significant varus angulation and comminution, kind of going back to what Hertel taught us about that importance of that medial hinge. In patients who I'm not really sure about, and I saw one of these the other day, I'll bring them back to clinic within a week, and then maybe even a few days after they first present. And if the fracture position is worsening or changing significantly, suggesting that it's a really unstable fracture pattern, and again, I'll think about surgery. And then the last one for me is the most important. I think you'll soon realize that most upper limb operations don't make a huge difference to people, perhaps with the exception of instability work. The main reason we operate on people's upper limbs is to get them back to what they want to be doing quicker. And Prof has shown it to us, and also your own personal experience, I'm sure, shown you that if you've got somebody who is a manual laborer, or a surgeon uses their arms quite often and needs to get back to their day job or looking after their kids or whatever, surgery might well help them do that. So that's a really important factor in determining what to do. Now, you guys all know when not to intervene, but undisplaced fractures, as I've said, things I'm not really sure which way it should go, I'll on the side of not doing anything. Of course, if anybody says to you, I don't want an operation, you'd be crazy to try and do something. And also the patient factor. So if you have somebody in your clinic room or you see in A&E and you just think, this patient's going to do bad, whatever we do, don't make a mistake of going through with surgery. I haven't really spent much time talking about what to do, so I'm just going to whittle through a couple of slides, just because I know you're probably all eager to turn the telly on. But these are just a couple of examples. So head pointing in the right direction, young person, I fixed it. Look at the calcar here, look at the bone quality, look at the displacement of the head in this patient. For me, this was going to do badly either way, went straight to having a reverse. And actually, for me, I think reverses do pretty good. And this is that patient 3 months down the line, and did great. And I don't think you're going to get that quicker recovery with fixing elderly patients with X-ray looking like that. Displaced surgical neck fracture, that's got non-union written all over it, but this patient did really well, just healed up. Scapula provides all the movement that they need. Head pointing in the wrong direction, they got fixed. Then you start worrying about missing bone. Look at that calcar, doesn't really line up properly. Comes back, collapsing AVN. Oh dear, this is going to do terrible. But actually, this patient did absolutely fine. No pain, reasonable range of movement. Wasn't that bothered about it. You've got to treat the patient, not the X-ray, right? This again, I thought, fix it. Did fine. Came back, screws pointing out, and just be wary of phyllos plates. The most common, up to a third of patients will have prominent screws. Now, I'll probably just whiz through this because I'm almost out of time, but we're looking increasingly at reverses versus hemis, although not many people do hemis anymore, versus not doing anything. And obviously that's what Prof 2 is looking at. For me, I generally think that in the elderly population who's got a fracture, bad fracture, doing a reverse, if it goes well, they do great compared to leaving them alone. Lots of studies have shown us that the older you are, the better they do. And lots of studies also show that stemmed hemis do really well. And I think one of the reasons why this happens is because once you've cemented in a hemi, unless you've got a really good reason, you'd be crazy to revise it. So when you look at NJR data, it's, cumulative risk of revision being low in hemis doesn't mean that they're good implants. It means that people don't really want to revise them. I know I've whittled through things quickly, but the only other thing that I wanted to leave you guys to think about is we refer to Hertel's papers, Gerber's papers, and these really big studies which taught us a lot. You look at some of the pictures, and this was one from Hertel's. I mean, when was the last time you ever saw a proximal humerus fixed with a third tubular? So when you start looking at things like this, you've got to scratch your head and wonder, well, actually, are all these studies really out of date? Do we need to really think about revisiting all these topics with up-to-date technologies, modalities, and patient groups? So I'll leave you with that thought and see if anybody has got any questions. My email address is there. More than happy to be contacted about any questions or clarification of any of the points I've made. So thanks, everyone.
Okay, so Nick, there's a couple of questions for you in the Q&A box. The first question is from Sanjay Shetty, and he says, you just want to hear about predictors of delayed and non-union of the proximal humerus fracture, please.
Do you know, I don't think a non-union is a risk. It's a risk of kind of AVN and collapse. So I won't put the slide back up, but I think it was the fourth or fifth slide which showed the risk of AVN following a different fracture pattern type. So in the ones that, the 4-part dislocated head, then the risk of AVN goes up to about 75%. But the problem is we don't know whether that AVN is clinically significant. So people can have collapse, they can have portions of their humeral head which, have died, but does it matter? We don't know. Or it's not that we don't know, it's very difficult to predict whether or not that's going to influence the patient's outcome. As I said, it's not like a hip. You have AVN in your hip, you can't walk, you'll die sooner. That's not the case with the humerus. It just means that your hand's by your waist rather than up here.
Cool, thank you. And then the next question is from Gianluca Gonzi, who says, do you think if Profa had put in reverse replacements versus non-operative management, there would be a different result? And then secondly, what do you use to decide between a reverse shoulder arthroplasty or an RF?
Yeah, that's a really good question. I think the first part will be answered because Profa 2 is looking at that. So it's looking at the use of reverse hemis or nothing. So we should get the answer to that. What do I use? It's tough. This isn't a science. It's not like those binary hip surgeons which just use 4 figures, 1, 2, screw 3, 4, osteotomy more. It's not that straightforward. And, and I know it sounds a bit cliched, but you really do have to look at patient factors, the, anatomy of the fracture, and then come up with your conclusion. I really think that if you pick your patients wisely, then a reverse is a fantastic option because they really can get back to what they were doing much quicker than if you're having to put a Phylos plate in. And actually, it's a dead easy operation to do because you've got literally no exposure. Normally, when you do reverses, you're fighting to try and get to the glenoid, and it's a horrible operation to do, but for trauma, it's great. So as a result, I probably do more reverses than I should, mind you, but yeah.
Cool. So 2 more questions. Penultimate question from Will Morley, who says, when you're operating for, and there's a comminuted medial calcar, are you doing an RF because you're trying to restore the blood supply, or is what you're trying to say that you'd offer a total shoulder replacement as the blood supply is likely to have been lost?
Again, it's not that simple. It's not like the hip guys where you either have or you haven't. So if you've got like an exploded medial calcar and you just look at it and it's going to go really badly, normally in the elderly patients, they've got crappy bone anyway, so piecing it back together is quite difficult. In a younger patient, you're not going to do that. So it kind of goes back to what I was saying before. It's just completely dependent on what the fracture looks like. If you think it's not fixable, then you shouldn't fix it. If you're going to do anything, then you need to replace it. And there's been studies not only with the shoulder but also in the elbow, which says that if you decide, you should know what you're doing before you go in. So you shouldn't really go into a shoulder thinking I'm going to try and fix it, and if I can't, I've got the reverse kit on standby, because you'll have greater complications with those. So you should know what you're going to do beforehand. And then in terms of how to fix it and whether that matters, as I said, it's a soft tissue procedure. So for me, I do all my proximal humeruses the same way. The arms on a Mayo table, the head goes back into the right position. There's a Y going into the glenoid. Sutures around the tuberosities, they go through the plate, and then the plate goes onto the shaft of the humerus, and then everything gets tied down, and then I put the screws in. So the combination of the medial calcar doesn't really affect how I fix it or the difficulties per se, within reason.
Okay, thank you. And then for the final question, I'm not sure whether Rishi is actually typing an answer or not. My screen says he is, but let's try and answer the question anyway. So Juliet, oh, no, he has answered it, so you've escaped.
Oh, that's all right. What was the question? Let's finish off on it.
Okay.
Is there a difference between function doing a reverse sooner or delayed reverse? Yes. Doing it primarily is way better because it's a much easier operation. There are less complications. People have better outcomes. So yeah, there are studies. Then I couldn't quote off the top of my head. But yeah, for sure, the sooner you do it, the much easier it is. And yeah, as Rishi says, technically, a reverse is a horrible operation. They're not nice in an elective setting because you're always worried you're going to break something. Getting that glenoid properly exposed, and also it comes with kind of worn glenoids and really thick capsulitic tissue. I say it's really horrible. I think compared to kind of doing an acute one for trauma. With trauma, you open up, you can see the tuberosities there, you move them aside, and you're looking straight down into your glenoid. And it's dead easy. It doesn't give you as much chest pain as doing it for non-union. I think I've got one next week or the week after, mind you.
Great. Thank you very much indeed. George?
Yeah, thank you everyone for your time and for attending, and thanks again to our speakers, some excellent talks there. Just a quick reminder, you'll get a link for some post-webinar feedback. If you could please fill that in, it really just helps us to keep track of how we're doing with these talks and make sure we're getting things at the right level. And we'll see you all next month for some spines, and enjoy the rest of your evening.
Thanks, guys.